Tobacco remains the #1 preventable cause of death in the state of Oregon. Tobacco kills 7,000 Oregonians each year, which is roughly the population of Walla County. An addiction to tobacco starts during childhood. 90% of current adult smokers started smoking before they turned 18. Practically every person I know, including myself, has a story of a family member or a very close friend who's been touched by this scourge of diseases caused by tobacco use.
Thanks everybody for coming to celebrate the success of Measure 44 in curbing tobacco use. As a physician, there's perhaps no more valuable endeavor to protect my patients' health than helping them stop consuming tobacco and keeping others, new tobacco users, from starting. Doing something sensible like raising the tobacco purchase age could reduce teen smoking rates by as much as 25% in the state. Every disease has its cure, and efforts like this are the treatment. But tobacco and tobacco-related illnesses aren't cured yet, and I'm asking everyone's help here and throughout the state and Central Oregon to help encourage our representatives in Salem to pass Tobacco 21 legislation through the House this session.
You know, public health understands that by convening partners, that's how we get the work done. We do that in many areas in public health, not just tobacco work, and we understand that part of that is collaborating with our coordinated care organization. The conversations between public health and the CCO, Coordinated Care Organization, really focused on what are opportunities that we can look at health outcomes and really work together, and tobacco is really one of those opportunities to improve health.
PacificSource's CCO has partnered with our county health departments in Central Oregon to help our members quit tobacco in a variety of ways. Muriel mentioned the Regional Health Improvement Plan that has some specific indicators and health outcomes that we're working towards in the next few years. We also have helped collaborate and funded with the OHA the Tobacco Quit Line Interface project that kicked off earlier this month, which will leverage our health information technology resources to enable a closed-loop referral system to occur throughout our region and send directly to and from the state's tobacco quit line. We expect that this will increase the rate of referrals significantly and, of course, therefore help to improve our cessation rates regionally. We also worked with our county health departments and the OHA to wrap our regional transit bus system, and so that was already mentioned earlier. These types of health communication campaigns are a core strength of our public health in this region and the kind of support that health systems can really use to improve our health outcomes.
This region, which includes Crook, Deschutes, and Jefferson counties, as well as the Confederate tribes of the Warm Springs, is an example both of innovation and leadership. It's forging pathways from the clinic and the hospital to the community for improved health.
In 2016, the Central Oregon Health Council implemented its first joint project to improve tobacco-related health outcomes. And this was really a community-based strategy to really look at how can we make a difference. And by leveraging financial support with State Public Health Division, with the Central Oregon Health Council, the 3 health departments were very engaged in this process and helped move it along. Also, we engaged with the Central Oregon Intergovernmental Council, where we're sitting today, and really looked at implementing a mass media health education campaign to support current tobacco users to use the quit line. And I think that is really important, that we really look at a number of strategies to affect public health and work on the tobacco issue. So this collaboration really succeeded from the collective strength and expertise of the coordinated care, public health, state health division. I think we really look at how many partners do we bring to the table to really create these kind of strategies.
Oregon passed Measure 44, which increased the price of tobacco. And that's kind of what we're celebrating today, the celebration of this 20 years ago. It solidified Oregon's commitment to health and dedicated a portion of the revenue to activities that work to prevent youth from starting to smoke and to help people who are smoking to quit. In 2017, this year, the 20th anniversary, tobacco prevention and education activities have reached every county and have reached every tribal nation in Oregon, thanks to the collaboration of individual communities coming together to set that goal. Nearly 2 out of 3 Oregonians who do smoke currently want to quit. And because of Measure 44, we have a tobacco quit line, which opened in 1998, making Oregon the very first state in the country to offer to help tobacco users who want to quit. And since 1998, Oregon Tobacco Quit Line has helped close to 140,000 Oregonians quit tobacco. In 2004, Oregon became the first state in the nation to provide nicotine replacement therapy to Medicaid members who called the quit line. And today, Oregon is a national model for helping people who want to quit. Our model is built from the experience and the dedication of local governments and coordinated care organizations working together, the kind of work we're celebrating here today. So Central Oregon shows us what it looks like when healthcare, public health, and community organizations and consumers sit down together and create a common investment in a healthier outcome for their community. The investment Oregonians made 20 years ago in tobacco prevention supported this region to build a model for collaboration between public health and healthcare that now can be quickly translated into other health outcomes.
In 1996, it was really that partnership that got ballot measure 44 on the ballot and helped to make sure that it passed. And Oregon is unique in that we do have this sustainable infrastructure for tobacco prevention, and that's really something special. We have an ability to understand what's going on in our communities and to be able to react to it. And that, as was said earlier, the tobacco industry is always evolving, and it's you guys in the community that let us know what's going on so that we can get you the data and the information and the support that you need to address it in your own community.
So getting started, this is really just an opportunity to provide a statewide overview of what's happening in the state, and then the moderated conversation is going to get more specific to what's happening in Central Oregon. But really, there's some context that has inspired some of the conversations that we're having throughout Oregon. The first is the Affordable Care Act. The second is some of the leadership that Oregon has taken in implementing the coordinated care organizations and the Oregon Health Plan, and more recently, and as it relates to tobacco, the work that the Health Evidence Review Commission has done, which has really set forward a path for coordinated care organizations to implement evidence-based tobacco cessation benefits and multi-sector interventions, which sounds a bit wonky, but is really reinforcing what you all have led here in Central Oregon, which is that opportunity for public health and health systems to come together to do things like a bus wrap and a communications campaign. We know what works in tobacco prevention, and because of ballot measure 44, we have 20 years of experience here in Oregon implementing interventions to prevent tobacco use and work with the other 50 states and territories to really set forth good population health approaches. But as you can see in these, increasing the price of tobacco, protecting people from smoke, and helping people quit, and using campaigns to inform that. This is not something that public health can do alone. This is something that requires partnerships and collaborations. So again, I mentioned earlier some of the policy context. Something specific to tobacco that I really want to call out that the Affordable Care Act set forth and that Oregon's coordinated care organizations through the Health Evidence Review Commission really solidified. And I will say, whatever happens at the federal level, what we've got here in Oregon is really solid. And that is gold standard benefits that are required for all coordinated care organizations to provide, which includes covering all of the FDA medications with no prior authorization, making it really easy for a doctor to write the script and the person to actually go down to the pharmacy and pick that up versus needing to check in with their health plan first. That had created a barrier, and that was removed here in Oregon. The other thing that the Health Evidence Review Commission did, and we are the first in the country to do this, and we're working through the growing pains as we do this, is added more traditional public health, population-based approaches to the prioritized list. And in Oregon, the Health Evidence Review Commission that determines what is on that prioritized list, that is what Medicaid or the Oregon Health Plan has to provide its members. So whether you're a member of a coordinated care organization or you're in fee-for-service, any plan has to provide what's on that list, down to whatever the budget allows for, which the legislature determines. And that what the Health Evidence Review Commission did that was so unique is when they updated the tobacco cessation benefit line, they included this multi-sector interventions note, which really started giving leeway for health plans to contribute to media campaigns, which we saw here in Central Oregon. Trillium in Lane County did something similar, and also made it easier for them to participate in more population policy-based approaches, like what Dr. Boddie had talked about in regards to advocating and supporting Tobacco 21 or other types of important tobacco prevention legislation. So because of that, the Public Health Division really saw this as an opportunity to support coordinated care organizations and local public health departments in coming together to determine what's going to work best in their community for implementing some of these multi-sector interventions, particularly around tobacco prevention. And so we created a grant program referred to as Sustainable Relationships for Community Health. We are now at the conclusion of our second year of this. Deschutes County with Central Oregon CCO was one of our first grantees in this endeavor and did some pretty spectacular work to identify individuals who use tobacco, refer them to the quit line, and then get information back from the quit line to the doctor so the doctor knew what had happened and that their member was successfully quitting or had a really good effort and is going to need continued support.
So I'm really looking forward to hearing more today from our panel and continuing to talk about bringing these sectors together and learning from each other and what we can do to improve the health of all Oregonians. First of all, what role do you or your organization play in supporting tobacco prevention in communities?
I think our job at the state level, you've heard about the Tobacco Prevention and Education Program, which was funded through Measure 44, and what we try and do is to make sure that these resources are available to all Oregonians throughout the state, so that this work is going on in each of our counties as well as with our tribal nations. The other responsibility I think the state has is to really identify best practices and to do evaluation in conjunction with the communities.
As a physician taking care of patients in the clinic one-on-one, one of the sad things that I get to do are treat firsthand tobacco-related illness. A lot of my patients suffer from the after effects of tobacco, and either ongoing or a long history of it. So I also get to do kind of the fun part, a lot of screening, tobacco-related counseling, trying to help people quit, because there are very few smokers or tobacco users that don't want to quit. They're just stuck there. It's an addictive substance. And then for my other job, kind of as a city councilor, some of the work on tobacco retail licensing and some of the legislative policy decisions that we're working on, that's really the other side of that coin. So those are the things that don't lay it all on the individual and don't make it all the patient's job, but it helps support the patients and the individuals when they're ready to quit.
I think the CCO role is largely a supportive one. We're supporting the work that Dr. Boddie and his team and Muriel and their team and others are doing in the community for tobacco prevention. So we're largely supporting our provider partners and community-based organizations.
Are any of these roles different than they may have been in the past?
Looking at this higher level of how do we create those policy changes that really help people stop smoking, and that is very different than it was years ago.
We're turning from making it the individual's problem and the individual's responsibility to something that's more of our society's responsibility to fix this before it starts.
The biggest difference is now where people come together at the beginning to decide what is the goal they want. So if this is the goal, friendly competition,
Right.
that's part of, we want everyone to succeed, but we focus on the goal, and it's not a program, it's a systems approach. And what do each of us across the continuum of this system have to do to contribute to that goal? And I think that not only is a more successful, as Muriel outlined, approach, but it's also more efficient.
What would you say are some of the recent successes?
I think from a state level, we've been talking a lot today about the two recent initiatives for tobacco prevention, about the communication campaign for the bus wrapping and then also the tobacco quit line interface. Both of those couldn't get off the ground without the support from the state. So the state funded a third of or a half. Yeah, Deschutes County did the work. PacificSource and the Oregon Health Authority helped split the cost. They split the cost for the buses. So we'd never seen a proposal like that before. So that was fantastic. Of course, it made it very easy to say yes to. Then we also got a lot of support from the state. And then we've also, certainly the tobacco quit line interface has gotten a lot of technical support from state folks. So there's a great partnership, not just locally, but also with our state folks as well.
But it really is multi-sector partnerships that help bring kind of the RIP to, well, here it's not a CHIP, it's a RIP. So it's Regional Health Improvement Plan.
We're extra special.
Yeah, we're special. And I think it really brings that to life because we have so many partners working on those. So we have housing and we have, kindergarten readiness, and we have all these different work groups. And I think that's, when I think about the work we do, that's those multi-sector partnerships that are really important, and it does take a lot of time. That is the one thing I will say, but at the same time, it's really worthwhile.
The Oregon Health Authority has these quality incentive measures that asks every CCO to go forth and do well on these quality measures. It's been really fantastic, though, to have this money infused so that we can use it for community reinvestments, because that's what we've decided as a region in our community governance structure, is that we'll take 40% of all the dollars that we get on their performance and use it for community reinvestments. And that's how we helped fund the bus wrapping and the tobacco quit line interface and lots of other multiple projects to reinvest back into the community. So we're just the manager of the money, and really all of the work is being done by all of our fantastic partners, of course.
The more we make something systematic or built into our process, the less it's on an individual clinician to remember to do it every visit. We have a significant load of things that we're working through in a patient visit or through our length of time that we care for a person. And the prompts that we get to, hey, it's time for tobacco cessation screening. We do that annually. Every visit, if somebody is a smoker or using tobacco, every visit we're then talking about that, and that's then getting logged into our EMR, so it's prompting the rest of our staff to check back in with that patient. And then with our partners and insurers and the public health folks at the state, then we're getting things like medications that can help with tobacco cessation covered so that the patients don't have to pay for that out of their pocket. Because indeed it's much cheaper, right? If we pay for that, it's far cheaper than paying for the lung cancer down the road. And we're starting to recognize that, I think, and really start to coordinate all those systems together. And the most recent and the encouraging thing that we're working on in my clinic is coordinating our EMR, which is called Epic, so that I can order tobacco cessation. I'm talking about it with a patient, and then that patient then gets a phone call from the quit line at the state level to follow up, close that loop.
How about any challenges that you face?
Since we've been talking a lot about our community governance process, I always say when it works so well and it feels so good and everybody's on the same page and we've all unanimously voted. And when it maybe doesn't work or it's harder, it just takes a lot of time.
I think the other challenge is, hey, we're up against a multi-billion-dollar global sort of marketing and industry apparatus that's selling something that people become addicted to very quickly and easily, that sort of sells itself. So we're fighting against a pretty big systemic process, and physiologically nicotine is just a very tough thing to stop using. So we've got that deck kind of stacked against us. Fortunately, I think there's an awareness, and I don't hear from my patients at any age that that they sort of don't understand that smoking's a risk and that it's bad. I think we're over that hurdle. Now it's a matter of how do we get patients to the help that they need to stop, so that they're not just out there on their own trying to fend off commercials, television, flavored products for children, this sort of flying in the face of our whole society.
One of the challenges is having the humility that you might have a partner that knows more about something than you do. And I think, for public health and the healthcare system, we speak different languages. And sometimes they say population health and I say population health, and we find out we're not talking about the same thing, So we really have to, one of the challenges is to make sure you're talking about the same thing, and that you can defer to, someone else's expertise and figure out how to put it in the quilt, as opposed to having to do it all yourself. And I think that's a big challenge in any, robust collaboration.
How do we push the Central Oregon Health Council towards policy? They hear me say that a lot. So it's not just about our individual agencies doing policy work. It's about this overarching Central Oregon Health Council that has a lot of power and a lot of individuals and a lot of agencies to really help us think about these policy issues.
What does the future hold for tobacco prevention?
It's harder sometimes to get policies in some rural counties as opposed to some other counties. And I think part of it is, it's easier to get your commissioners to support statewide initiatives at times. So when we look at retail licensing, when we look at some of those things, the statewide push for those things really helps everyone in the state. And I think when I think about the future prevention work, it's really thinking about how do we support that, those kinds of policy initiatives at the statewide level across the state, so it really helps all Oregonians, because there really are disparities in specific communities around tobacco use.
Well, I anticipate that we'll have more referrals to the Tobacco Quit Line based off of the closed loop referral system for the Tobacco Quit Line interface. It's pretty cool that this region is going to be the pilot for the state. So I know it hasn't barely started, but really looking forward to seeing how it does here, of course, but then also how it rolls out in other regions. And so to be kind of the trailblazer on that is pretty fantastic. I also think we're getting just better in general on making data-driven decisions and making sure that we're using data to inform where we're going.
Do you see this partnership and this work applying to other aspects of health?
I think, in many areas, if we're talking about diabetes prevention, I remember way a long time ago in Douglas County doing a diabetes prevention program that was really a lot about population health. You probably remember those. And, we know what happens, we know what needs to happen in the medical community, but at the same time, there's some things that can really happen in the community around diabetes. So I think there's other public health issues that there isn't, part of the challenge in Oregon, and it's part of the reason we're looking at modernization, is that there's so much categorical funding. And so you really want to focus on these things. But I do think the opportunity of working with our CCOs and looking at what our metrics are and looking at what's the role of public health in this around the population efforts. So I see that as a great opportunity. And that's just one example. I think there's many, but I think diabetes is another one we could take a look at.
I think we could take any chronic disease,
Right.
And think about risk factors, hypertension, diabetes, heart disease,
Right.
smoking, tobacco, and anything. If we take a look at the entity and then look at the external environment that's contributing to that, and then target those forces, that's applicable to any
To
chronic
any,
disease.
yeah.
That's
Absolutely.
preventative health. That's really what it is.
What advice would you give to your peers in other parts of Oregon who are just getting started on this work?
I'm always telling my peers it's really important that you reach out to your CCOs, but it's challenging because the structure is so different everywhere. But I do think you still have to be at the table. So no matter what, you still have to think about how do I get to that table. And it may not be you, it may be a commissioner, but you still have to push that envelope.
I think my advice would just be very simple to work together, collaborate, and sorry, but you need to meet frequently. And,
Yeah.
and you need to meet face to face.
It's a recurring theme.
I know, it's unfortunate, but I think that that's part of what makes it work is face to face meetings on a regular basis. Otherwise we'd just be behind our computer screens anyway.
You can't have a conversation if you have nobody from the other two counties at the table. And so I think it's also speaking up and saying, it's really important that we make sure we have voices from Warm Springs and we have voices from Jefferson and from Crook and from Deschutes. And in Deschutes, La Pine and Sisters. And, there's a lot of other communities. So it's really thinking about how do we bring that whole, and it's hard work to get people from many of those more rural areas to come to the table. And I think you have to make an effort. And I think that's another thing we really work at.
Well, thank you all very, very much. I really enjoyed this conversation, and I want to thank our panelists. I think that I was sitting here thinking the tobacco industry would love to make sure that there were no community conversations about tobacco. And that's the first thing that they try to get rid of when they target tobacco prevention are the community efforts that address this issue. And the reason is that you at the community level are so effective. And I think that we've seen that here today. And I'm really proud of the work that you're doing, and I'm really pleased to be here, and thank you very much.